Good afternoon, everyone. How are you? I feel very blessed to be here. I would like to actually ask, as I say a few words, that our panelists come on up. I'll introduce you when you're about to speak. So Frank and Peter and Paul, please. Frank's going to speak first, and then Paul, and then we'll round out with Peter. But as they're coming up to the podium, I wanted to share with you a bit of my own personal experience as to why I think this panel is significant. Before I joined AID, I ran a small nonprofit called the Center for Interfaith Action. It's where I met Shepard and others. And one of the board members, Mark Dybel, who you might know from PEPFAR days or who ran the Global Fund, said to me early on that his fundamental belief was that Christian and religious faith-based institutions had far better quality of care than others. But what was missing was the proof. What was missing was the evidence. And so for me, it began a journey of seeking where are the facts, where is the evidence, and where are the stories that demonstrate the extraordinary value added that faith-based organizations bring to the realm of healthcare. Because then when I joined AID, despite the fact that it's an agency with decades of experience of working with faith-inspired organizations around the world, there was no common theme to demonstrate why it was in the agency's interest to do that systematically. So what we're going to hear today is some wonderful data, some stories, some initiatives that really go to the heart of the conference's theme. Faith is at the center of quality, sustainable health. And I know you all believe that, but part of what we need to do is ensure that that story is being told outside of this forum. So I'd like to start with Frank, whom you all know, who has 40 years of experience in primary health care and beyond around the world, who's going to set the stage for us in looking at a number of different countries. So please join me in welcoming Frank. Each speaker is going to talk for about 10 minutes.
Oh.
I hope, or less. Chris, Chris is going to be putting up a little note saying, you know, you've got 5 minutes or stop now, please. And then we'll have an interactive session afterwards.
All right, thinking inside the box. Paradigms for health system strengthening with FBOs. I'd like to start with a question. Which of these two pictures would you hang in your office? Would you rather the one on the left side or the right side? If you chose the left side, that means you're a left brain thinker. If you chose the right side, it means you're more of a right brain thinker. Left brain thinkers tend to think more in terms of logic, right brainers with their imagination. Left brainers are concentrating on details where right brainers are concentrating on integration. And so between those two, left brain thinking and right brain thinking, which ones do you need to do integration of FBOs into health system strengthening? You need both, of course. And that's what we're going to talk about. But I think from my perspective, there's some tendency that FBOs think outside the box a bit too much, and I want you to think about FBOs inside the box being the health system. Rather than working around the health system, how do you work through the health system? Here's another example. If I would give you this maze and tell you put your pen on the green dot and work your way from A to B, I'm sure that in a couple of minutes, all of you would get from A to B. It's not that hard. But if I was to put someone up here and say, put your pen on the green dot, and you have 2 seconds to get from A to B, what do you think would happen? I've done this before, and most people, the adrenaline kicks in, they're out of the box thinking starts, and they go from A to B. And then there's the other type who starts and they go through the box, which is really 3 different styles of management. Inside the box, around the box, or just bust straight through the box. This is kind of represents the styles of managing health system strengthening. And it goes back to my favorite paradigm that I show just about every presentation I make at CCIH. This comes from David Korten. He put it in his book, Getting to the 21st Century. He wrote this back in the 90s. So it's a classic. And it behooves you to get that book and read it. Because he talks in there about 4 generations of NGOs, and I equate that to FBOs, development strategies. And I don't have time to go through all 4 generations, but the important ones are that a lot of FBOs concentrate on doing relief and development. In fact, when you think about it, many, if not most, NGOs started as relief organizations. I worked with Mennonite Central Committee. MCC started as a relief organization. Oxfam started as a relief organization. They gradually started doing more development, but they began in relief mode. And organizations that work in relief mode have a particular style of working where their concentration is getting relief, getting assistance to families and to individuals, and it's the work of the NGO who is the doer, and their challenge is logistics management, getting assistance to the community. And in doing that, they often need to work around the system, rather they don't have time to work through the system. So that's very legitimate, but it's not health system strengthening. The 4th generation that Korten describes is called sustainable systems development, which I would equate with health systems development. And that is where an NGO or an FBO works as a catalyst in collaboration, bringing together public and private sectors at the district, at a regional, or at a national level in strategic management to build health systems. That's working, what I equate with working inside the box. And what I'd like to do is give some 3 quick examples from Congo, Liberia, and Haiti, where I personally worked with these issues. And suggest 4 steps. The first step being, and you'll see my bias here, is to first map, I'm a big mapper, map the FBO assets. It could be health facilities, it could be churches, it could be schools, it could be advocacy groups. From the Ministry of Health perspective, they want you to map the facilities. How many hospitals, how many health facilities do you have that you can collaborate with in the system? The second step is analyze the health system strengthening environment. What is the structure of the national health system? Is it a health district? Is it a health zone? Is it a community health unit? How is it structured? And then how can our FBOs fit into that system? Third, develop a country-specific strategy. And the emphasis here is on country-specific. You know, when I left Congo and started working as a freelance consultant, I thought, well, I can just share Congo's experiences with other countries. I found very quickly that other countries weren't interested in Congo. They wanted their own country-specific examples, specific, tailored to them. And it's really necessary to work within the historical context of a country and the relationships between the FBOs and the government to have a country-specific strategy for collaboration. And then the 4th step is to decentralize implementation. Rather than trying to do the collaboration from a top-down, can you create an environment where you can do things from a more decentralized level and then build it up? These 4 steps are what I call MADD, M-A-D-D. So you can remember that acronym. map, analyze, develop, and decentralize. Now, I realize that there's another acronym, another NGO or a group that uses MAD. That's the Mothers Against Drunk Driving. That's okay, we can share it with them. There's also a lesser known group that uses this same acronym. It's the Mathematicians Against Drunk Deriving. So we can all be mad together. The first example is from Congo, which I represent here in my attire. Back in the 60s, Congo had a very good health infrastructure, believe it or not. There were more than 400 hospitals decentralized across the country, half of them owned by the government, half of them owned by the churches, Catholic and Protestant churches. So in mapping that, back in the 60s and the 70s, the government realized half of our hospitals are run by the church. We can't ignore the church. As we decentralize the health system, we need to work together with them. So in developing a strategy, and this dates back into the mid-70s, they developed a strategy to collaborate with the faith-based groups to create decentralized health zones. And the key point there was that they did not follow administrative boundaries. Normally, countries will decentralize and follow county boundaries or district boundaries, which ultimately ends up being the government hospital being the center of the health district. In Congo, they said a health zone will be created around a functional hospital. So whatever hospitals are most functional, theirs will develop the health zones. And it was a very wise strategy. And that allowed for a decentralized development of the health system. And this is what the original SANRU project, which started in 1981, helped the government implement. Very, very unique project. And then it was funded by USAID, but the contractor, the implementer, was the Protestant Church of Congo, who managed the project on behalf of the government of Congo. And that project started creating the decentralization by working with Protestant hospitals and establishing the model for health zones, and then these percolated up from the bottom. After 3 years, the government had created about 100 of these health zones. From the bottom up, they started bumping into each other, and it was only at that point that the government worked with the hospitals to make a delimitation of the health zones and came up with 306 health zones. And that delimitation became the solid foundation for Congo's decentralized health system for the next 20 years, of which half of those health zones were managed by church groups. So the church was not just providing 50% of the health services, they were managing 50% of the health zones. And here you see a map that implements that shows that. Liberia is a different situation. I went to Liberia in 2006 and began working with the Ministry of Health. I made more than 20 trips to Liberia, helping to develop a national health strategy. And with that, trying to take into account the faith-based network, the network of CHOW, Christian Health Association of Liberia, which is what you see in the map there, the red dots with the yellow centers, and the blue hospitals. That represents the faith-based organizations, health facilities within the country. So the thing about Liberia is that it's structured strictly around the county health system, which puts the FBOs at a disadvantage, because when you concentrate on the county health system, then the center of the county, where the government hospital is, runs the show, and the FBO hospitals become secondary hospitals. Not that that's not important, but it's a different approach for collaboration. In Liberia, there's actually only one county, Bone County, where Phoebe Hospital is actually the hospital that, in effect, manages the county. But in But the collaboration with the church groups was very good in Liberia. That wasn't the problem. The problem in Liberia was different in that in 2006, 80% of the health facilities were being run by international NGOs who were receiving humanitarian assistance. And you know how those things go. An NGO writes a proposal, they get funded, they do their own thing. So you have a dozen different NGOs in the country doing their own thing around the system. Not necessarily bad. I mean, they're working in humanitarian mode, so it's justified. But once you're in that humanitarian mode, how do you get out of it and get into development mode? Transitioning from humanitarian assistance to development assistance is one of the biggest challenges that I've encountered in a number of countries. And in some sense, the NGOs would say, oh, well, that's fine, just give us money and we'll do development work. When you go back to Korten's framework, you'll see that NGOs who are specialized in doing relief and development work aren't particularly good at doing pure health system strengthening work. So in Liberia, the strategy of the ministry began to work with the donors to restructure the funding and get the donors who were diversified and uncoordinated to coordinate their assistance year after year. So as the years progressed, the donors consolidated their assistance, and the purple dot there represents an area where instead of contracting out to international NGOs, the government contracted in to the county health teams to manage the health systems. And this continued to improve through 2012 and 2013. The last example I want to do quickly is in Haiti. Haiti has 140 communes. I can't really see the boundaries of the communes there. But the green dots there are the government hospitals. The Constitution says that they will decentralize to the communal level. And the interpretation of the Ministry of Health was that each commune should become a health district, meaning each commune, the interpretation at the community level was each commune would have a hospital. But you only got 30 government hospitals for 140 communes. So it wasn't possible to do that coverage. When you add in the FBO hospitals shown in the red dots here, the situation improves a little bit, but there's still not enough infrastructure there to do 140 communes. So the strategy had to become to redo the communal effort, and instead of a communal health unit being one commune, it became 2 or 3 communes. And by doing a careful mapping of that, it was then possible to align the infrastructure of the hospitals with this regroupment of the communal health units for coverage of the country. The implementation of that was sort of spotty. A lot of other problems have happened in Haiti. This concept is still there. I think it's still on the drawing boards in Haiti. It's been partially implemented with some NGOs, with Pignon, with Hospital Albert Schweitzer, but it has not been implemented across the whole country. 2 final thoughts. First, if you're going to work through the system, learn about the national health system. What is the unit for decentralization? Is it a health district? Is it a health zone? And what are the parameters of that? The more that you know about that structure, the better you can collaborate with them. And then secondly, establish an ongoing dialogue with the Ministry of Health where you can discuss how you can collaborate together in health system strengthening, particularly in leveraging the resources that the FBOs have that the government would not have, that can complement each other in doing health system strengthening. I conclude with some words from the famous philosopher Calvin, which most of you know as Calvin and Hobbes. Calvin and Hobbes is probably one of the most famous comic strips of all time. Calvin is a 6-year-old with a stuffed tiger and a brilliant imagination. But if you're an avid fan of Calvin like I am, you will know that Calvin uses boxes with great imagination. His box is a duplicator. or his box is a time machine, or his box is a meeting house, gross meeting house. That's girls, getting rid of slimy girls. Or it's a duplicator, or it's a box to sell happiness or swift kicks in the butt. Hobbes would conclude with a philosophical statement, it's amazing what they can do with corrugated cardboard these days. If he was here, he would say, it's amazing what they could do with FBOs these days. And Calvin would respond, go CCIH. Thanks for listening.
Thank you so much, Frank. Now I'd like to invite Paul Mikov to come up. Paul is gonna, he's got a wonderful, while he finds his presentation, he's with the Catholic Medical Mission Board and has an extraordinary breadth of perspective, particularly as relates to partnership and innovation. So he's gonna share with us some nice thoughts about that. Thank you, Paul.
Thanks so much, Kathy. And welcome everyone. Thank you for welcoming me here. It's a delight to, for the first time, attend the CCIH conference. I feel dwarfed after Frank's presentation, considering his depth of experience in the field and know-how and knowledge of the national health systems. I suspect that despite the fact that CMMB is a 105-year-old organization, very few or not very many of you will have ever heard of it. I wasn't very much aware of it until just a few years ago. Historically known as Catholic Medical Mission Board, a couple of years ago refreshed its brand a little bit, certainly the look and feel, and added a tagline, Healthier Lives Worldwide, still known most widely as CMMB. What I am going to try to accomplish here in this very quick or brief presentation is twofold. First, I want to walk you quickly through the 3 or 4 main portfolios of CMMB's work globally and seek to underscore the necessity but also the possibility of modeling programs or designing programs in such a way that health system strengthening is central commitment and organizing principle to those programs rather than a standalone initiative or standalone program of its own. Now, of course, my intervention here should not be understood as an exercise in self-promotion, much less self-congratulation, because health systems are so complex and strengthening those systems is a complex endeavor that comes with huge potential for humbling us, and that happens practically on a daily basis. And secondly, I want to refer your attention to an ongoing initiative in digital health that also directly relates to the topic of our meeting tonight. So CMMB is really about the health of women. It's about the health of mothers and children. That is our point of departure because we realize that change really starts with women, with mothers. Central to who we are and how we operate is also the notion and the commitment to partnerships, increasingly public-private partnerships, blended models, and so forth. But really at the heart of everything that we do, we aspire that it be related to and geared towards strengthening the health systems with which we interface and interact. This is a map that illustrates the footprint of the portfolios that I'm going to reference in a minute, perhaps in greater detail. But the starting point ought to be really this recognition, and this is really introductory and a prelude to my argument about the necessity and the possibility of modeling programs in a way that's health system strengthening is really central and dominant. These are the internationally accepted, internationally recognized core functions of health system strengthening. Human resources for health, health finance, health governance, health information or health informatics, medical products, vaccines and technologies, and service delivery. So it is in the context of these six that CMMB actually seeks to align and integrate its programmatic work with health system strengthening. Perhaps the program for which CMMB has been best known and more widely known internationally is this partnership that it has had for perhaps decades now with the pharmaceutical industry. Literally the largest pharma companies are our partners, with whom we jointly deploy somewhere between $300 and $450 million worth of medicines, health commodities, medical products into 35 plus countries every year. Now, this is a program that intentionally seeks to work with hospitals, clinics, dispensaries, partners, global down to national levels, and consignees, where the need has been already identified and where our deployments would actually contribute in a significant way to the expansion of access to medicines and increasing the quality of those medicines and health commodities, as the needs have been indicated by the hundreds of organizations, typically hospitals and clinics, with which we partner and whom we supply with medicines, health commodities, and medical products. What we are, as we speak, working on quite diligently is the commitment that we made just a little over a year ago of about $500 million towards the implementation of the Sustainable Development Goals. I'm sure all of us know about them, and in particular the third health goal of increasing the deployment by at least 30% of medicines, health commodities, medical products into the 13 so-called highest burden countries. Highest burden countries in terms of maternal and child morbidity and mortality rates. So this is a goal that helps us really be strategic and structuring it around the notion of strengthening the health systems by expansion of medicines and health commodities where the need is the greatest. CMMB has also established its reputation over the last certainly 15 to 20 years in the area of HIV and AIDS, as many of your organizations have done and others that are not represented here. However, what we are at present specifically working on and trying to be intentional about is to work with health systems that operate in the area of HIV and AIDS in a way that it helps them increase their responsiveness and their capacity and ability to preventatively be much more effective, and especially as it relates to the demographic of adolescents and adolescent girls in particular, how to help these health systems to be much more effective in preventative and screening endeavors and build capacity and know-how in those areas so that we can prevent HIV infections or HPV infections and any other sexually transmitted diseases and ailments among this immense, huge demographic of adolescent girls who are really at the greatest risk. The third area, which relates to the very first internationally accepted core function of health system strengthening, is in the area of strengthening the health workforce where we work. And we seek to do that in two ways. First, through the deployment and embedding of professional experts in the medical sciences. Typically, these have come from North America and the global north into health systems, hospitals and clinics in the developing world. We're now much more intentional about doing this on the basis of South-South cooperation and seeking to recruit doctors, nurses, public health coordinators, increasingly individuals with expertise in areas like dentistry, pharmacology, even some of the backroom functions of IT, communications from the global south, deploying them and embedding them into health systems, into other countries within the global south. So a Zambian doctor into a Kenyan facility. And this, for organizations like mine, to which you may be associated or belong, you know, these sorts of programs are incredibly transformative. Here on the photograph, you have Dr. Rachel Consoli, a doctor who spent 12 months in South Sudan last year, who did incredible work at the clinical level by performing literally hundreds of surgeries, but importantly, in the context of health system strengthening and strengthening of the health workforce. Within the 12 months, she did over 25 training sessions that resulted in transferring of knowledge and know-how and competencies among over 250 staff in multiplicity of systems in South Sudan. The other component to the strengthening of the health workforce within health systems is through this program of building capacity among over 3,200 healthcare workers worldwide associated with our programming. As we speak, we're working with a couple of organizations, the goal of which being is to capacitate these 3,200 health care workers, community health workers, with tablets or mobile smartphones, and with integrated and built-in applications that help them deploy mobile health competencies and linking those with the health systems, hospitals and clinics with which they are associated, and with the communities among which they work. The program that is rapidly becoming a flagship initiative for CMMB is CHAMS, which stands for Children and Mothers Partnerships. Now, this is a typical maternal and child health initiative that is not hugely different from the alternatives that Save the Children has, World Vision, and other similar organizations. However, this is a program that I think it is differentiated by a beautiful element, and that is exactly in the fact that each of these CHAMS programs, and we deliberately implement this initiative in 5 countries to avoid organizational overstretch and ensure that there is focus. Zambia, Kenya, South Sudan, Haiti, and Peru, similarly at very different countries. So each of these CHAMS programs is deliberately anchored to or linked to an already existing health system. Typically a larger referral hospital with some outlying dispensaries in the more rural areas where the access is really minimal. Not limited to private hospitals or mission hospitals, a combination of state-owned as well as private hospitals. Now, what is the significance of this notion of anchoring these programs to health systems? Well, the significance is in the fact that ideally a CHAMS initiative results in 2 sets of outcomes. First set of outcomes that are a consequence of the traditional interventions that everybody else does that does work in maternal and child health, from immunization of children to water, sanitation, hygiene, nutrition, etc. But another set of outcomes also in strengthening the health systems to which we have anchored these programs, tackling bottlenecks, dealing with inefficiencies, bringing in infrastructure and building capacity, oftentimes bringing in new technologies, etc. I have been told I have very little time left. I have to rush through this. Another component to this CHAMPS initiative is the notion of collective impact on the understanding that healthcare, provision of healthcare is really by design multi-dimensional, multidisciplinary. And so we seek to build partnerships and mobilize various other players across domains, governmental, non-governmental, corporate, faith-based, etc., in order to infuse into these health systems competencies across different areas of expertise and sectoral capacities. This is an actual hospital in the southern part of Haiti that CMMB just this past March formally launched and opened. Beautiful facility by Western standards even. As you can see in the background, the setting is incredible, therapeutic in and of itself, because the background is the beautiful Caribbean Sea. It is going to serve the needs or provide access to primary care to a population, underserved population of at least 50,000 people. Now the question is, it's beautiful. I was there in March, met with key leaders in the government, UN and all that. They're all impressed. But a big question is, how do we actually create extensions of these fixed assets? Because underserved populations in the southern part of Haiti go in the hundreds of thousands. So we're considering right now mobile clinics. However, and this is a segue into my last section, a promising area, a necessary area is the whole information technology, information and communication technology. And in that context, quickly, let me refer you to an initiative that is ongoing right now, a two-phased initiative. We have just wrapped up the first initiative in digital health. We are doing this in collaboration with the Hilton Foundation, but we have really created a public-private partnership, leveraged the involvement of KPMG. I'm sure most of you know about KPMG, Johns Hopkins University, which has a Center for Information Technology in Public Health, health-enabled, and of course ourselves as those that lead the initiative. And it is an initiative specifically geared towards building capacity at the institutional and personal professional level among a constituency that unfortunately is too often under the radar of anybody involved in health provision, namely Catholic women religious, or more popularly known as Catholic sisters or Catholic nuns. I suspect that most of you know that behind the largest private health system network on the planet, which is the Catholic health system, are the many orders in the thousands, orders or congregations of Catholic sisters and nuns. They have been the generators, the genesis of that whole immense program on the globe are really Catholic nuns. I do not come from a Catholic background, and so I've been fascinated over the last number of months to get to understand this domain. There is so much great work happening there. However, as Frank told us, we need to help this domain, like other domains, to begin to operate much more within the box, rather than continue to operate outside of the box if the box is a national health system. So the idea here is to help these many hospitals or clinics that are in the majority of cases owned and operated by the various orders or congregations of Catholic sisters, or systems within which Catholic sisters as administrators, nurses, public health or community health coordinators are embedded and operate and function to build capacity and new competence, and over time, hopefully, new confidence to deploy and to use digital health, electronic health, which is more facility-based, and mobile health, more field-based, and to exponentially increase their ability to address issues such as patient tracking and reporting, community health workers' operations and public management, integration with program design and program management, and many, many other areas in which digital health can be consequential and is increasingly becoming necessary. I could tell you so much more about this exciting initiative. We just finished the landscape analysis. KPMG have been leading the landscape analysis in Africa. By the way, this is an initiative across 6 countries, 3 in Africa, 3 in Latin America and the Caribbean. Johns Hopkins University and Health Enabled working in Haiti, Peru, and Mexico. And maybe if you would allow me to conclude by referencing testimony by our colleagues at KPMG in Africa, who lead KPMG's work in healthcare across the African continent. These are people that know their work, and they told us recently how their expectations were very, very small as they were about to begin to work and interface with Catholic women religious. To their shock and surprise, pleasant surprise, they have found, they said, in Africa, Zambia, Kenya, South Sudan, these Catholic nuns to be incredibly compelling professionals in their own right, with PhDs, master's degrees, bachelor's degrees, who have been for years and decades self-sufficient, but have developed incredible expertise. And we're excited that through this initiative, we're going to be able to help amplify the great work that they're doing. And importantly, for the topic here, this initiative is going to have a dual effect on health system strengthening. It will strengthen the systems that these nuns and sisters operate in, but it will also help strengthen the respective national health systems as a whole by integrating and helping this whole domain of Catholic women religious interface electronically and digitally to a much greater degree with the overall national health system. Thanks so much.
Thank you, Paul. And I'll invite Peter. So we've had Frank give us this marvelous view of the health systems box. Paul with a vision of partnerships, of how to strengthen health systems in different ways. Now we have Peter, who with the Christian Health Association of Ghana represents a significant portion of the Ghanaian health system. Now, I would urge you all, after Peter's presentation, we will be opening it up for questions. So if you want to begin thinking about and jotting down your questions, we would like to take as many as possible after Peter's presentation.
Yes, thank you very much, Kati. Hello, everybody. I think we are all Christians, so we believe in Trinity. And we've had one powerful presentation from the Father, from the Son. This is a time for the Holy Spirit. Okay.
Sorry, I hid the device up here.
Okay. A presentation from Ghana. Christian Health Association of Ghana believes that an improved and sustainable health outcome is a direct result of health system strengthening. So my presentation will be looking at CHAG, a brief nature of CHAG and mission, and our main collaborators or partners. And then I'll be looking at the CHAG health system strengthening model with a focus on health financing and how it influences universal health coverage and its impact on the entire health system. Highlight few achievements, modest one, and challenges, and then come out with lessons learned. Briefly, the Christian Health Association of Ghana, CHAG, is a network of 25 denominational groups with 302 health facilities. That is highly noted for efficiency because with 5.5% of health infrastructure, it accounts for about 30 to 40% of healthcare in the country. CHAG is recognized as an agency or implementing partner of the Ministry of Health. Very exciting, but it has its own challenges. We were established in 1967, so this year, CHAG is 50 years old as an association. And I thought you'd say hooray to that. Wonderful. Wonderful. Right. CHAG has had a very interesting partnership arrangement with the government of Ghana. And this has been evolving over the past 50 years. And come the 2000s, we felt that there was a need to formalize this relationship because it was quite loose, subject to certain turbulence. So we have a partnership or relationship with government that operates at both the policy and operational level. So in 2006, we felt that there was a need to formalize these nice arrangements where government pays salaries. So we led a team, we negotiated with the government, and we signed an MOU accompanied by administrative instructions. And the MOU defined exactly how CHAG will relate with the government on all the health system building blocks, service delivery, human resources. How do we provide services within the governmental framework? And this MOU signed with government confers certain rights and responsibilities. For us as CHAG, we were responsible for policy implementation and ensure that we comply with certain regulatory regimen. In return, the government was supposed to guarantee salaries of our staff, grant us certain exemptions, tax exemptions, and ensure equitable resource allocation. At the operational level, we also signed an MOU with governmental agencies, the Medical and Dental Council, Health Facility and Regulatory Agencies, and Ghana Health Service, as well as the National Health Insurance Authority. CHAG has a unique health system building block arrangement. Our health system strengthening is based on 9 building blocks beyond the 6 adopted by WHO. We believe that community participation, partnerships, and research are vital elements, and they have synergistic effect throughout the system. So that's how CHAG operates, and CHAG adopts the 9 health system building blocks. Now, we want to demonstrate how certain initiatives could have fundamental effect to the entire health system, how the Ghanaian health system was strengthened by this initiative. You are aware that in the 1980s, government of Ghana was compelled by the IMF, one of its conditionalities was that remove user fees. So it brought in this way what is called cash and carry, user fees at the point of service delivery, and it had certain consequences. It led to catastrophic healthcare costs for families, so there was this financial barrier to healthcare. And suddenly, OPD attendance in the whole country declined by 25%. We felt that was huge. And those who were hugely affected were the poor, the marginalized, and the neglected. And because CHAG was located mainly in the villages, in the remote areas, we felt the impact of it. We never sat down, and that's why we felt that there was a need to really initiate something that would impact at the national level and also at the network level. So in the 1990s, late 1990s, CHAG pioneered and piloted 40 community-based health insurance schemes and see how can we have some form of insurance for the poor and the needy, those who were affected by this user fees arrangement. Then suddenly, after successful piloting, it took a political twist. The politicians wanted to fraternize with us. It became a campaign promise in 2000s. So we had a new government who said, well, I want to have a national health insurance scheme. And in doing so, it was CHAG that was enlisted to come up with a technical advice on the design, adoption, and implementation of such a scheme. So it led to legislative instrument, Act of Parliament. But before we realized, the government nationalized all the 40 community-based health insurance schemes to become the National Health Insurance Scheme. We just gave up because we felt that we were not in competition. We were supposed to complement government health services. So we agreed, and we felt that that was a leverage. But how did we achieve this? I'll come to that. We were able to mobilize the community. We leveraged our huge social capital. We had a bond with the community, so they enrolled in such a scheme, and we were advisors of the government. So what has been the impact of this initiative at both levels? We measure impact of our initiatives on 2 levels, at the national level, as well as the network level, CHAG member institutions. So just look at this table, very interesting. The scheme, the seed that we sowed many years ago and that was nationalized, had this impact. Now from 2005, when the scheme became operational, active membership moved from 1.3 million to 8.9 in 2012, up to 10.5 million in 2014. That was a phenomenal increase. Active member, that represented about 45% of the population of Ghana. Outpatient utilization moved phenomenally from 598,000 in 2005 to 29 million in 2014. Inpatients also went to the same level. But interesting area where your attention might be drawn is claims payments. In 2005, the scheme was in honeymoon, heavily supported by development partners. So we were only paying 7.6 million Ghana cedis. And in 2014, 968 million. These were highly successful. It was acclaimed. Ghana's scheme was acclaimed as the best in Africa, as the best poverty reduction strategy. And that was very exciting. The government was basking in glory, and all of us were happy. So that was a national impact at the level. But how about CHAG network members? Suddenly we realized the need to strengthen the health system. So some of the few effects that have been categorized, the service delivery, human resource technology level 1. Now, out of 100 patients visiting our OPDs, CHAG member institutions, 98% are members of the National Health Insurance Schemes. And 92% of inpatients are card bearers of the National Health Insurance Scheme. It means that financial barrier has been removed for several people, especially in the villages, the communities. Now, phenomenally, CHAG member institutions increased with assurance that whatever you provide, service provision will be paid for. We moved from 192 before 2000 to 305, representing almost 60% membership increase of the Christian network. Because we had guarantee, if you establish a clinic, your salaries will be paid. One, and then all clients who were coming hitherto, who were absconding, you wouldn't have any problem. And then we were forced to improve service delivery package. Why? Because clients were now dictating, if you don't ensure that, if you don't have one-stop shop of service package, they may not choose your services. So we were forced to improve service delivery, even including mental health services. How about human resources? As part of the accreditation requirements, you needed a certain caliber of staff. So it led to recruitment and retention of professional staff. Continual development, professional development programs were there. In a sense, quality also improved because you were supposed to supervise your clients to avoid claims and then complaints of your NHIS members. Technology, the Catholic Health Service, which is part of CHAG, instituted pool procurement, and that led to 30% reduction in cost of procurement. Suddenly, within CHAG, tracer drug availability of essential medicines improved from 75% to 98%. It means that health insurance helped us so much. How about leadership? CHAG was also strengthened to ensure that all members ensured regulatory compliance, accreditation requirements, credentialing, and everything. We ensure that every member, because the health insurance forced us to uphold rules and regulations. Accountability was there because we're supposed to submit claims on time, claims processing will be conducted, and some level of discipline. How about finance? Now, 90% of our internally generated fund came from the National Health Insurance Scheme. So you see that the health insurance was just indispensable for survival. There were several benefits, but let me look at community participation. Clients became powerful because clients had the right to choose. And in it, there was this capitation payment that ensured choice and competition. Clients had to choose your facility, and therefore clients began to feel empowered. Patients' rights came in. It also led to social accountability. This is fine. But then suddenly you found several countries visiting Ghana, and we must be very excited. At the country level, high impact, network members, high impact. But is Ghana's National Health Insurance Scheme the best? It ought to be the best, don't you think so? It showed results. Hey, 10 years or 12 years into the scheme, we were hit with the reality. We experienced chronic delays in reimbursements, 11 months in arrears. The scheme could not pay the huge claims that were coming. What were the effects? Service providers felt crippled. Suppliers of medicine were not paid. There was acute shortage, and still, of essential critical medicines that is there. And suddenly there was this general loss of confidence in the entire healthcare system that was really there. Do we need to sit down? CHAG felt we had a duty. But let me demonstrate some of the pictures. Look at clients. So dejected, and still they are. Dejected from the best shining star to the hard reality. So the scheme, in effect, suffered financial sustainability challenges. We had rapid implementation, fantastic results. We didn't plan well. We felt that the benefit package was too much. But Chad always has a role when there are crises. That's why our health system resilience comes in. So the government, realizing that we were the grandfathers of health insurance, contacted us. The president set up a 5-member committee, and he called the executive director in person to be part of the committee to review the national health insurance scheme, because we were probably the hub of it, not to excite ourselves too much, but I think we were the grandfathers, faith-based organization, credit to all of us anyway. So a presidential committee was set up, and we had a remit to ensure that we review, retool, and repackage the national health insurance scheme to make it more sustainable, efficient, accountable, and to the utmost satisfaction of the entire country. Finally, the recommendation that came out was that child position was affirmed, and the recommendation said that primary health care at all levels, including child facilities, must be guaranteed. I mean, the recommendation was there, and my presence in the committee was to ensure, protect the interests of my organization anyway. We did very well. So suddenly there was change of government, and the new government didn't really seem to prioritize national health insurance scheme so much. Patients, providers, everybody was just crying. So we reminded the government to still prioritize NHIS very well. But there are challenges. There are challenges of collaborating with government. At one point, you are collaborating. At one point, you are a critic. So this dual identity is a big challenge there. You must collaborate in partnership there. And then also, active involvement has a risk of stifling your true identity. If you fraternize too much, you have a problem. And there are changes in politicians and policies. You must still maintain with them. There are also risk of assimilation and loss of identity if you over-fraternize. See, within 1 year, we have had to deal with two ministers. In 2016, this was a minister of health. Less than 6 months, we had another minister fraternizing with. And then you have a new CEO of the National Health Insurance Authority. I'm forced to fraternize and see him all the time. So what are the lessons? We need to formalize our engagement with stakeholders. And if you want to strengthen partnership, you must be nuanced in policy analysis, lobbying. You must be somebody who, the system should be aware of how to partner properly. But we must also build leverages. We need technical skills in insurance. We must offer solutions, plausible solutions to government. And we must always ensure that indeed the trust that we have so much, through connection and contact with the communities, is leveraged in dealings with government all throughout that are there. So take home message: if we want to ensure sustainable development goals, we must adopt health system strengthening, and partnership is an important pathway. And faith-based organizations, as we are, we have better prospects and potentials in championing health system strengthening all throughout to ensure that our advocacy and accountability mechanisms are well shared. We have one leverage, mobilization, and reach across board. And sustainability of quality health systems is a guarantee when faith-based organizations are involved. Thank you so much.
Thank you, Peter. Thank you all. So now is the time for questions. The way we would like to do this would be to listen to 3 or 4 questions. I believe there are going to be some roving microphones. There we go. So don't be shy. I know this group is not shy. I'll go ahead and ask a first question, and I hope that if you would like to ask a question, can you go ahead and raise your hand? My first question will be to Frank. Frank, you gave us a paradigm of how to move from the relief NGO to an integral part of the system. You also showed us country examples where you started by mapping assets, faith assets. What recommendations would you have for faith-based organizations that go beyond the assets and the physical infrastructure? And what do you see that might be unique? But let's take 3 or more questions while Frank is thinking about that. Who else has a question? Let's listen to some. The lady in green at the front. Perhaps you could identify yourself.
Sure, I'm Dr. Don Harrison. I'm a Norwegian at American Association of Pro-Life Norwegians. So So how do you handle the conflict between what government requests sometimes, you alluded to in your talk, and your identity as a Christian or a Catholic organization? That's for any of them.
Okay, thank you. Any additional questions for now? Anyone? Okay, the gentleman in the back.
I'm Yeboah from World Council of Churches. Historically, the World Council of Churches has been involved in establishing Christian health associations. Now I think it's not going on anymore. And one of the countries which I know there is no unified network is DRC. To what extent do we think it is necessary to have a national Christian health association? And if it is so, what can we do to support countries that are still working individually as churches? Thank you.
Okay, thank you. So, actually, is that microphone on as well, the one in front of Peter? Yeah, so Frank, do you want to start?
Okay, I want to start with a question for Tony. Where is Tony from Uganda? Is he here? Okay, because what I was presenting is a very narrow slice of the pie, and it's a specific approach in using mapping of assets, physical assets, as a leverage point for discussion and dialogue with the government. One of the slides that I dropped out of my presentation because it was too long was the dichotomy, the problem we have with private versus public sector. That's the way the literature defines the system, public and private. And where are the FBOs and the NGOs? Technically they're on the private side, but they aren't really private. They're more public than they are private. And so part of the challenge is how do we shift the FBOs, the NGOs, the recognition for them to be more in the middle or on the public side. And the only country I know that seems to have done that is Tony in Uganda, where they have succeeded in getting the discussion, the dialogue, to talk about public sector, not-for-profit sector, not private for-profit sector and private not-for-profit sector. I tried to introduce that terminology in Liberia and just drew a blank. Not that the ministry wasn't collaborating with the NGO, the FBOs, but they weren't interested in using that terminology. So that's another area that I would suggest I think that improving that terminology could help us improve the leveraging of FBOs in discussion with the government. So I'd be interested in knowing what Tony's experience is in Uganda. Has that been a successful approach, or are there pitfalls in using that three-sector approach?
So before we hear from Tony, I think, Peter, perhaps you could address the second question.
Yeah, thank you very much. I mean, your question resonates so much. It's about risk and rewards of collaborating with government. As I'm observing the presentation, CHAG has survived mainly because of government support, salaries, and the rest, but it goes with risk. Because we feel that as Christian organization, we should represent the moral voice, represent the poor and needy, whatever. So we ensure that at all policy formulation levels, we maintain the moral voice, Christian voice that are there. And luckily, we always seem to be providing solutions to some of the challenges government has, technical solutions. So they see us as allies. One of them is that during strike action by public sector workers, quickly we take advantage, we build a leverage. I will issue a letter instantly that CHAG hospitals are not part of the strike. And government feels relieved, the president will call, thank you very much for supporting us. And the next one will go to the president, Mr. President, we need this. You remember the last time when they were having strike? So that was one area. But one of them is also that we observe that about 80% of all policymakers and politicians are Christians. So we use faith leaders and engage them through the back door. So we may have confrontation, but then we have a way of engaging them behind closed doors, because politicians are very fluid. We also use this way. We identify their needy areas, vulnerabilities, their constituents, and where we have the only Christian facility there, we ask, are you prepared to let this hospital collapse under your watch? So it's always about trying to identify where are my strengths, where are my leverages, and it is a daily task of scanning and scoping within the sector, seeing their vulnerabilities, leveraging your strengths. It works, but with hard work.
Thanks, Peter. Paul, any comments?
Yeah, Kathy. Perhaps one observation from our experience is that really the issue is not so much the unwillingness of governments to interface with faith-based organizations, etc., especially in countries like South Sudan, where they are so dependent on faith-based providers. I mean, CMMB, for example, does the management and the operational work in one of the largest state-owned hospitals in Yambio in Western Equatoria in South Sudan. But it seems to me that one new emerging area is in the fact that as many more of these for-profit private systems begin to emerge in the developing world, many of the mission hospitals or private not-for-profit faith-based, typically faith-based systems are going and are rapidly being pushed out of the market. They're not as sustainable as they used to be when so many more resources were coming into these health systems from the global north. So one area that we, I think, must jointly begin to seriously look at, and luckily thought leaders in global health like Gates Foundation have growing interest in this area that is called strategic sourcing. In other words, as governments, quite a few of these developing governments are increasingly able to budget more resources based on economic growth in many of those countries, more resources for their own healthcare. We must actually position ourselves to be able to be providers of health services which will be procured for, therefore paid for by those governments. And this is going to be an alternative, a parallel to the growing trend of for-profit corporate health systems coming and emerging in these settings.
I'm afraid we're almost out of time, so we probably don't have time for another round of questions. What I would like to do is to ask each panelist to take 30 seconds, and if you have one final message or recommendation for the group, what would that be? Now, Peter, since your presentation was last, you get to go first, and then Paul, and then Frank will have the final word. But before you go, Peter, we all want to wish Chag a very happy 50th birthday.
Thanks so much, everybody. It is apparently intuitive that faith-based organizations or faith-inspired health organizations have an important role in all health systems because of our rich accountability systems and our desire to promote Christ healing ministry. What we lack is our inability to brand, maintain visibility, inability to mobilize our strengths very well and be a bit, I don't want to say aggressive, but then we have capacity issues. We need to recognize our essential role so that we can always build the necessary capacity to promote, project, and protect the needy, especially the poor, the marginalized that we represent so much within our system. And this is where I think that partnerships, South-South cooperation partnership among faith-based, which is not really prominent, ought to be highlighted. And I'm going home with one, take-home message. CCIH could be more relevant to all faith-based organizations, especially in lower middle-income country, give them hope, strength to mobilize and position itself strategically to ensure that the sustainable development goals become more closer and become actors and players and champions of health system strengthening. Thanks so much.
Sure.
Well, Peter, you're absolutely right. I think we have a unique opportunity to do incredibly well in the area of health system strengthening as a faith-based domain because of a unique convergence of factors. I already mentioned one, and that is thankfully a growing number of the developing world is increasingly experiencing robust economic growth, and therefore greater degree of domestic resources to be channeled in healthcare. Secondly, as part of the post-2015 process of articulating a new development strategy, the Sustainable Development Goals, the whole sustainability paradigm presents a great opportunity because the developing countries themselves recognize that health system strengthening is a core and must be a core priority over the next 15, 20 years. Thirdly, the incredible advances in technology. So deployment of information and communications technologies come with the potential to really revolutionize the provision, the expansion of the provision of healthcare, but also increasing the quality of healthcare. And of course, these are only three of many more of these factors that are beautifully converging, creating an incredible historic opportunity.
Thank you, Paul. Frank, you have the last word.
All right. There was a question about the DRC. Can you have a Christian Health Association in DRC? So my quick response to that is no, I don't think it's possible. Just the historical context in Congo, it's too big, it's too decentralized. Unless you can find something that leverages the interests of everyone to work together, I don't think they can come together in an organization. And that's not necessarily bad. There are other ways to work around that. My concluding remark, well, the second thing would be, everybody talked to Tony during the break, and getting to tell you about the three sectors in Uganda. My conclusion would be that health system strengthening is really in the eye of the beholder. And we all come at it from a different perspective. I come at it from, mapping perspective, to use that as a starting point. Peter was talking about using the health financing as the kind of the entry leverage point. Paul was talking about the Catholic nuns. Boy, and they're a great resource that I've worked with in Congo too. There's a fantastic breadth of assets that FBOs can work with. So please don't go away defining health system strengthening as being mapping health facilities like I was suggesting. That's a narrow wedge of the pie, but celebrate the diversity of approaches and how we can integrate that together as part of overall health system strengthening that's really specific to particular countries.
Thank you, Frank. Well, this concludes the opening plenary panel. I want to please join me in thanking our panelists, who I think were terrific.